Professor Suranjith Seneviratne with us today, DPhilOxin, MBBS, MD, DPAT, MRC PAT, MRCP, FRCP, FRC PAT, FCCP. Professor Suranjith Seneviratne does not need introduction to this audience. He has been a regular speaker at several conferences. He's the professor and consultant in clinical immunology and allergy at the Institute of Immunity and Transplantation and Health Services Laboratories, London, UK. And he will be talking to us on investigating a patient with suspected allergy, a practical approach. Over to you, Professor Seneviratne.
So let me thank Harsha and the council for inviting me to give this talk. Prof. Saman mentioned about Harsha being his registrar, and there were 2 years before that, I think, because Harsha was the HO in the unit. I was the registrar at that time, and Harsha was the HO, and Prof. Saman was the senior consultant. So it's great living back there and recalling those memories. And here, what I'll do is speak to you about, I was asked to speak to you about investigating patients with allergic disorders. And this is a sort of a 20-year sort of journey that I've gone through. It's close to 2 decades of working in allergy. And I was trying to get out and try to speak on COVID. And every time I was directed, please, can you talk on allergy rather than COVID? Because COVID is the topical topic now. So I will take a sort of patient approach. How do we approach a patient talking about food allergy, aeroallergens, and about drug allergy, and how do we explore those different conditions? So the sort of basic presentation, the sort of summary would be the basic aspects, clinical aspects, aeroallergens, food, drug, anaphylaxis, MCAD, mast cell activation, diagnostic aspects, and management. I'll just go through certain aspects relating to these. We know the immune system it's designed to get rid of bacteria, fungi, and viruses. If it doesn't work well, you have immune deficiency. If it works in an abnormal way, like it starts reacting to innocuous substances in the environment, then you get allergies, and certain people get autoimmunity, but we are dealing with allergies at the present time where you react to innocuous substance in the environment. The immune system should not react to those things in the environment. What are the important cells here when it comes to viral infections? Lymphocytes. When it comes to bacterial infections, neutrophil. In allergic condition, it is the eosinophil and the mast cell. Predominant cell, not that the other cells are not important, but eosinophil and mast cells are important from a pathogenetic mechanism. And I will talk about those aspects because those are important clinical aspects. The eosinophil is a very, very sort of fascinating cell, lots of receptors, lots of mediators, and people can have increased eosinophil counts due to a whole range of causes, and that's a common condition that we see. And with asthma also coming in with eosinophil, that's an important cell to be taken note of. Then you have the mast cell, the resting mast cell, the activated mast cell that has released a lot of its chemicals out into the surrounding tissues, etc. And that again can aggravate the allergic manifestations. There are lots of mediators in the mast cell, and you can see that there are lots. Hello, can you hear me? Hello? Yeah, there are lots of mediators in the mast cell, and these are some of the mediators. So when the allergen binds to the IgE on the mast cell, it cross-links it, sends a signal, and all those mediators are released into the tissue and then causes its effects. Next, we know some of the mediators that are released include histamine and tryptase. You can see that the histamine is released very, very rapidly. And then you have the tryptase that is released a bit later. And that is important in working out when to take these blood samples, because you wait a small period after reaction and take the blood sample. So that is an important sort of chronological sequence of how these chemicals are released. Now we have to remember that not all allergy is IgE. So you have IgE-mediated allergy, but you have other mechanisms. You have T-cell mediated, etc. And that is important because in a patient with IgE-mediated allergy, you will do some procedures, while in a patient with T-cell mediated allergy, you will do other procedures. And if you get that process wrong, then your whole diagnostic aspect can be wrong and you make the wrong diagnosis. If we look at, this is so a representation of T-cell mediated allergies, and you dermatologists say it, allergists say this, and this has to be taken into consideration because it can mimic type 1 allergy, but the investigation and the management is different. You would never challenge a patient with the culprit agent if you have a T-cell mediated allergy, or you will do it very rarely or very, very carefully because it can exacerbate the whole condition. So when we come on to allergic diseases, you have problems due to aeroallergens, food allergens, drug allergens, insect allergies, latex, etc. And I will go through a few of these and tell you how to diagnose this and how to manage it. So this is the overview, because I thought of covering the area rather than going to each into detail in each topic. So I will start off with aeroallergen, food allergy. But that is an important aspect when it comes to Sri Lanka. Previously, I can remember in 2020, etc., or 2021, when I used to come to Colombo and offer to speak on allergy, nobody was interested in speaking on allergy because allergies were low at a low frequency in Sri Lanka. But now it is an important condition that has to be taken in, and how do you investigate them and how do you manage them? So air allergens, you have the house dust mite, pollen allergy, cat dander, dog dander, etc. House dust mite is so common around the world in certain times of the year, and can cause quite a lot of inflammation on the nasal nasal pathways, the nasal cavities, inflammation of the sinuses, etc., and cause a lot of issues, and can affect children's education. It can affect their working lives, people's working lives, and a number of medications are used, and desensitization is a process that we use in a group of patients, especially with pollen and house dust mite and pet allergy. So when it comes to food allergy, you would see that there is food hypersensitivity. That is, you have a problem when you take food. Not everything is allergy. In community setting, everything is mentioned, allergy, that sort of picture comes in, but not everything is allergy. There are IgE-mediated allergy and non-IgE-mediated allergies. For example, lactose intolerance can produce very similar symptoms, and you'll be treating it incorrectly if you don't diagnose lactose intolerance or celiac disease in another perspective when it comes to wheat. So you must differentiate it. Is it IgE-mediated allergy, or is it one of the other causes for food hyperreactivity? So an immune response to food is food allergy. Children have different common allergens. Adults have different allergens. You know, the shellfish, fish, beef, wheat, egg, milk, etc. are across the age groups. You can get these people having these different allergies. And sometimes detective process, and that was lovely talk that Prof. Saman gave, because the detective process finding what is the cause that is responsible for this person having these allergies. So signs and symptoms generally occur quite rapidly within 2 hours. It doesn't occur 2 weeks after that generally. Local symptoms can be skin, gastrointestinal, and rarely you can have the systemic involvement with anaphylaxis, and that is the one that you want to prevent. You want to treat them properly to prevent that occurring. We have to remember there is something called oral allergy syndrome that is due to pollen cross-reactive. Now, Sri Lanka wouldn't have it that much as in a European country where you have, due to birch pollen, grass pollen, or ragweed pollen, you have it cross-reacts with food. And certain people say that when they eat certain foods, they get tingling in the mouth, and certain more severe symptoms can occur. So this is the presentation of oral allergy syndrome that is generally found. It's a sensation in the mouth and in the throat, but in some people it can go on to more severe manifestation. The important clue to that is the patient comes and say, I ate an apple. When it was raw, I got this symptom, but when I took apple crumble, apple juice, I do not get this symptom. With their heat labile allergens, and they get destroyed by heat. And that is an important thing that we definitely teach juniors to be able to recognize. But the treatment is very important, avoidance of those, and treating the pollen allergy, because that's an important thing. And we sometimes use a fresh extract in doing the test, because if they come and tell that certain foods can cause a problem, because you don't have the reagents to test it, the synthetic reagents made to test it. Next important thing is food intolerance. It's an important aspect. Things like histamine intolerance and toxic due to certain fish, etc., enzyme problems, etc., has to be remembered, because if you do not remember these, you are going to misdiagnose and treat the person incorrectly. So please remember, food intolerance is there, and then you have food allergies. Food allergies can go to food anaphylaxis. That is why you have to recognize it. Food intolerance generally doesn't do it. You do not have a single test for food intolerance. Don't waste lots of money doing unnecessary crazy tests for food intolerance, which are sold on the high street and sort of different medical centers. That is not correct, because there is no good test for food intolerance at the moment. It's the history. Please take a proper history and get your diagnosis correct from there. When it comes to drug allergy, anaphylaxis, mast cell activation disorder, we know a whole range of medications can cause allergies, include the antibiotics, anesthetic agent, local anesthetic, and the other agents that I have listed in this slide. And you have to have a good history in getting to know what is the possible cause. The antibiotics that can cause allergies are given here, including the penicillin, cephalosporins, and the other antibiotic. It's very much easier to make a diagnosis and investigate when it comes to penicillin, cephalosporin, as opposed to some other allergens like vancomycin and the sort of tetracyclines, etc., which challenge testing can be a problem. But that is a picture that we would see in our clinics. And we know the beta-lactam ring, the antibiotics that have this beta-lactam ring, and the cross-reactivity, which I won't go into detail, but just give you a message here that intravenous administration can cause more of a risk. It has nothing to do, penicillin allergy, with mold allergy, because some people think that because penicillin was got for mold, that it is related. If you have mold allergy, you can get penicillin. Very commonly asked question from people. No, it does not have. And the important thing to remember is that history of previous allergy, please take note of that, because that is the reason, the commonest cause, people not asking people, are you allergic to something, and taking note of that. Many a times you have got referred patient where somebody has gone and given them a drug despite being told and despite them knowing that they're allergic to that agent. You cannot do that. You have to look for an alternative until that has been investigated properly. A whole range of anesthetic agents can produce allergies, or agents that are used in anesthesia. These are the agents that are listed here. We see a number of these patients in clinic, and we go systematically to work out what are the agents, muscle relaxants, or the hypnotics, etc., like propofol, can cause allergies, and we go very systematically in trying to work this out. So some simple examples that I want, or important example that I want to tell you, is about IV colloid. Remember gelatin. Gelatin can be present in certain vaccines, certain products that you give patients, and it can cross-react with certain sort of meats. So just remember this when it comes to gelatin and reactions that occur, especially with vaccines. Secondly, it is chlorhexidine. We use it in surgical procedures. Povidone iodine, the allergy is generally rare, seen about 6 patients in Sri Lanka with chlorhexidine allergy present in a different way. So please remember that this is an important consider to take, because they use it in mouth washes, etc. And then you may not, if you don't take a good history, you may not be pointed to the correct diagnosis patient. We have an easy test that we can do and diagnose this condition. Local anesthetic allergy is not very common. People complain of it, we investigate them, but it's not very common. It's mainly due to an agent entering the blood vessel, etc., or wrongly injected. That is the reason it is. So you investigate it and you reassure the surgeon or the person who's using local anesthesia, but it's not a very common allergy as opposed to certain other. Opioids do not produce allergy per se. It's very uncommon. It produces a release of histamine, and that's the thing. Morphine, pethidine, etc. releases histamine. So if you have a person with mast cell activation or histamine intolerant who can't break down histamine, don't go and load them with opioids post-operative. Use alternative agents if possible, which are going to worsen that person, and that person is going to get into problem, and then you would not know what you're dealing with, because there'll be the person has had a post-anesthetic or post-operative procedure. So remember, opioids release a lot of mast cell, especially morphine and pethidine release a lot of morphine, release a lot of histamine. And if we're doing a skin test, we use fentanyl and remifenil. Please don't use skin testing using morphine, because it's a utter waste of time. It will always be, it will be positive unless you're using it as a positive control. Next, we come on to NSAIDs. NSAIDs generally doesn't cause allergy. It causes not hypersensitivity, and it's such a different picture. There's nothing called very, very rare patients, extremely rare patients have IG, but it's generally hypersensitive because of a effect on the leukotriene path, the prostaglandin leukotriene pathway. And if the leukotrienes increase, you can get skin manifestation, you can get respiratory manifestations, etc. when taking NSAID. So please note this condition, because this condition, if a patient comes and complains of it, there are steps which I will discuss later on how to manage this patient with NSAID, especially when it comes to aspirin, etc. And a cardiologist wants to give in aspirin desensitization comes into picture. Samterstride has to be recognized. Quite a number of patients in Sri Lanka have this: asthma, nasal polyps, and aspirin sensitivity, respiratory involvement, plus skin involvement with regards to aspirin. Remember that, or other NSAIDs which are important, and that can be investigated. So anaphylaxis, what are the agents? So I told you about food allergy, aeroallergen, food allergy, and drug allergy. Anaphylaxis, you know that foods, insect stings, drugs, latex, and idiopathic, now we call it spontaneous, can cause anaphylaxis. The important thing is to systematically take a history and then do their test to be able to make a diagnosis of this condition. Very important. History is extremely important. Angioedema, common presentation. Most people are spontaneous. You don't have a specific cause for it, though you do the test. Remember that. Tell the patient that is important, but look for a cause, including food, including drugs, etc., because that may be important. Don't forget about ACE inhibitors, etc., and the rare condition of C1 inhibitor deficiency. So finally, I will talk in this aspect with the clinical measure, the important condition of mast cell activation disorder and histamine intolerance, which we described some time ago, 10 years ago, and worked a lot on this condition in the UK and also in Sri Lanka. And the important thing to remember, it goes with a group of conditions like EDS, Ehlers-Danlos, POTS, autonomic dysfunction, gastrointestinal symptom, urinary symptom, and other symptoms. Please don't tell this patient that they have something wrong with their mind, because that is a common thing which people think used to occur about 5 years ago in the UK, but now people are recognizing. So mast cell activation and histamine intolerance. I've spoken this about 3 or 4 times previously in Colombo, so I won't go into detail, but just mention that these two conditions are there. So I've told you about the clinical manifest, the range of allergies that can occur: aeroallergen, food, drug, anaphylaxis, angioedema, and mast cell activation. I have not spoken about insect allergy because of sort of reasons of time. Next, we go on to the diagnostic aspects with regards to allergies. You know, history is the most important. You do skin testing, fast testing, that's fluorescent antibody testing. You don't do RAS testing now because radioactive, we don't do it. And then certain patients, we have to go for an open challenge or a double blind challenge, which is the gold standard test that we do. So there are newer tests that are coming: component testing, patch testing the appropriate person with food allergens, etc., and the other allergen-specific tests that I won't go into detail because I've tried to make it more practical aspect here. Fast testing, use the UNICAP, that is a standard method. 0.35 was the sort of range. With drug allergies, sometimes we go down to 0.10. Please don't do those panels of 150 different allergens unnecessarily, because you get some false positive. And I've seen so many people bringing me those long reports of about spending about 40,000, which are absolutely no purpose, absolutely of no value, because it's a whole lot of positive. Any eczema patient will have all those positive, because eczema IG is high: 25,000, 15,000, 20,000. So just doing these big allergen panels on patients with eczema is an utter waste of time. Don't waste the time. Use it appropriately and do the appropriate, the more specific test. Skin peck testing is the gold standard. We use a skin peck test, very easy test, nothing majorly sort of complex in the test. You use the positive control, negative control, and the skin test, the appropriate skin test. We use prick testing at some time when it's fruit, etc., and do this testing. There's a whole range of other tests that we use in the UK for patient mast cell activation, histamine intolerance, serum tryptase, histamine, urinary histamine, methylhistamine, histamine release test, prostaglandin, leukotriene, etc., diamine oxidase activin, CK, and these are available. This is the allergy repertoire: skin testing, blood testing, appropriate blood testing, and a whole range of urine and blood testing to diagnose a specific condition. Because if you make the diagnosis, then you will move ahead and treat them appropriately. Next, we come on to when we do a skin test, the problem is that if you do soy skin test, it is positive. You think the person is allergic to soy, or if it is hazelnut, it can be allergic to hazelnut. But the important component that hazelnut is made up of number of proteins. It's not made of one protein, number of protein. And some proteins being sensitized. With skin testing, you only tell that the person is sensitized, not the person's allergy. The history is the one important for allergy. Sensitization, what you detect with skin testing. And the problem with when you get a soy or hazelnut positive, it can be any of these different proteins. So things have moved on. It is about 10 years that we have been doing this now for the last in the UK with regards to allergen component. We can really use molecular allergology and go on to working out, is it the whole protein, what protein in the what component in the protein are we reacting to? And this is the field of molecular allergology, because they have looked out the structures of these different allergens, and we can work out and say, this is the sort of component that they are reacting to. It's not present for all allergens, but for important allergens, like some of the nut allergens, etc. This is a very important advance in the field. So what are the traditional diagnostics we're using? The allergen extract, skin testing and blood testing, and now we are using component allergen diagnostic to be able to combine it with the other history and make a more specific diagnosis. We have a multiplex system where I use the Isaac testing, which is one step further. You can do component testing without individually, and then you have the complex testing, which is called Isaac testing. Again, I've given a number of talks before in Sri Lanka about this testing. Very easy system, which we use quite a number of patients in a whole range of allergic conditions, including food allergy and patients with eczema. We use this condition. What is the importance? Because certain proteins will produce severe allergy, certain components produce severe allergy, certain proteins will produce less severe allergy, and you don't have to take it as seriously and give them EpiPens, etc. Say in hazelnut, if I take it as an example, if you have core A8 and core A9, it is pointing to severe allergy. Could occur, but if you have core A1, that is pointing to more mild allergy, and that's important from insurance purposes, giving EpiPens, etc. And that's an important. Even with wheat, which is more common in Sri Lanka, you have a condition where you have omega-5 gliadin, and that leads to more anaphylactic picture with wheat. So that is the advantage of doing this component testing, because if we do the component testing, we can give a more prognostic indication rather than just saying you are allergic. So that is an important aspect to remember. Basophil stimulation test is another test that we use, especially in drug allergy and some food allergy. That is, you look at the stimulation of basophil and see different markers and see if it's positive or negative, which I won't go into great detail at this period of time. I will tell you the indications for investigating patient with penicillin allergy, because that's maybe a problem that you'll come across very frequently. If you have an alternative drug, please use the alternative drug acutely. Don't be wasting time and not giving the patient. Take a history, use an alternative drug, and then after you get over the acute situation, think of investigating the patient. And the important, unless it's an acute condition like CNS syphilis, immune deficient, close penetrator, where you have to use the agent, then you would go on and do it in a different way. But otherwise, treat with alternative agent and take a good history with regards to the drug allergy history. We use a different groups of testing, prick testing, intradermal testing, etc. And blood testing are not very good with drug allergies. So be very careful about it, because some people do blood testing, IG testing, and then say it's negative, and then they said that is not. You then have to go with a challenge test in the appropriate circumstance. If it's a IG mediated, not in a T-cell mediated, but instead of IG mediated, then this is the sort of challenge test we use. We use the dose that we use, how we build it up, the penicillin, the amoxicillin, etc., how the doses that we use. This is the challenge. I'll just go back there to the highest concentration. We use the dieta test, the PPL, the minor determinant, amoxicillin, penicillin, when doing the skin test for looking for patients with penicillin allergy. Very straightforward, not very complex, but you would investigate the appropriate person, because otherwise you'll be spending all your time investigating people who think that they are allergic to penicillin, and that would not be cost effective. You have to select your patients and investigate properly. Otherwise, your whole clinic would be only investigating. I think I had a problem with penicillin. My mom thought I had a problem when I was a baby. I can't remember anything. You have to be careful. investigate the correct group of patients. Next, you have with aspirin, we have do some aspirin challenge in the appropriate circumstance, especially when it comes to respiratory disease. If you want to investigate aspirin exacerbated respiratory disease, you have a protocol in doing challenge tests with aspirin, but you have to be very, very careful in this group of patients. So I've spoken to you about the clinical finding, I've spoken to you about the diagnostic aspirin, and next we go on to quickly about the management, good history, find out what the person is allergic to, and then treat appropriate. You have if it comes to aeroallergen, the nasal sprays, antihistamines, etc., which are widely used. Remember, give proper doses. Don't underdose them, because then nothing will be happening. Please tell them the correct method of using a nasal spray, or as otherwise they'll be treating their throat rather than their noses, and that is wrong. Desensitization is used in the correct context. Use it for the correct period of time, 3 years. I know that some people are using desensitization for 3 months. That's wrong. And use it. We use it for grass. We use it for house dust mite, pet allergy, etc. And use it in the correct perspective. You don't rush in as a first agent. You use the medical management. If it is optimal medical management not working, then you go ahead and think of desensitization. When it comes to food allergy, good avoidance measures is important. If you're allergic to prawns, you're allergic to prawns. I mean, that you can't get over it, at least in a short period of time. You have to avoid it and talk about cross-reactivity between allergen. Written treatment plan, you give them EpiPen in the appropriate circumstance. If they're having more severe symptoms, etc., they have developed symptoms, the EpiPen or the Jex we use, there are different doses for adults and children. And the important thing to remember is that you have to teach them how to use it, and when do you use it, are very important. And if it is a very obese person, be careful, because it may not reach the muscle which you have to give them injection to. So these are the different adrenaline auto-injectors which you use, and we also give them medical bracelet, especially if it's important to tell the other doctors on the medical team that a problem can occur, especially with food allergies and drug allergies and the anaphylaxis campaign. When it comes to penicillin allergy, if you do have to desensitize them, because certain people have to be desensitized, this is the protocol. We follow this one of the protocols. There are several protocols. One of the protocols, we desensitize, give small doses of the allergen over a period of time, and then they desensitize. But the important thing they should remember is that it has to be done by a correct person with experience, who knows how to treat if there's a problem that occurs. Who would you do aspirin desensitizer? Another common question in people where you have a therapeutic need for aspirin, or that is some other cardiac patient, you have to use aspirin, then you will do aspirin desensitization in a safe procedure. Aspirin exacerbated respiratory disease, you do it, or if they have multiple polypectomies due to the SAMTA triad, etc., you may desensitize them, but do it in the correct way and see if there are alternative drugs. I mean, if you have alternative drugs and you don't have to desensitize, don't rush into it. But if the indication comes in, then go ahead and desensitize them. And we have certain protocol that we use. When it comes to mast cell activation disorder, there are several drugs we use: high-dose antihistamine, sodium chloride ketotifen, and montelukast, and others, including omalizumab, which are used in a group of patients. Omalizumab is an IgE antibody, anti-IgE antibody, and we use that in the appropriate group of patients. So what I've done in this quick talk is given you an overview of the basic aspects of allergy and basic aspects of the cells, mast cells, eosinophil, spoken to you about the spectrum of allergic disorders: aeroallergen, food allergies, drug allergies, anaphylaxis, angioedema, mast cell activation, histamine intolerance. I've not discussed about insect allergy or latex. Told you about the diagnostic aspects: skin testing, blood testing, component testing, challenge testing, etc., and told you when do you use this test, and the basal stimulation. I've just touched that. And the management, make a diagnosis properly. History is important. Target your investigations properly. Don't waste money doing these broad-based tests which are of no use, panel testing which are of no use in people with eczema. And to target it properly, do your skin testing, do your component testing, and then you manage them appropriately depending on what allergen problem you have, and protect them from sort of severe conditions and getting into hospital except with the appropriate treatment that they should carry with them. Thanks a lot.